Good evening, everybody. I'm going to give it just a couple more seconds while we wait to see if anybody else joins us. I hope you're all doing well wherever you're joining us from. All right, I think everybody who was in the waiting room has been admitted. I'm guessing there'll be a few more that join us as time goes on. But welcome to the second episode of Focal Point, presented by Aniridia North America. My name is Janelle Collins, and I'm your host for this evening. I serve as the member at large on the board of directors for ANA, and I live in Florida in the United States with my family. My 14-year-old daughter has aniridia. During episode 1, for those of you who joined us, our focus was glaucoma and aniridia, and we realized that we just had way too many questions to answer in just an hour. So we thought we needed a part 2. So Dr. Netland has graciously been willing to join us again tonight. In case you weren't present for the first episode, I do want to repeat just a few of Dr. Netland's credentials. I won't do the whole thing. You can go back and watch that first episode for the full list. But he is the chair of the Department of Ophthalmology at the University of Virginia. He's also the chair of the board of Aniridia North America. He's a clinician caring for glaucoma patients and is also a very prolific investigator and author. He has a huge heart for the aniridia community. He's been increasingly involved in patient advocacy groups, research, and clinical care for patients with aniridia over the past over 20 years. And as I mentioned last time, he's also one of the kindest, most patient doctors that I've had the privilege of seeing with my daughter. So thank you, Dr. Netland, for being willing to join us here again tonight.
No, thank you, Janelle. What a nice introduction. I really appreciate it. And it is great to be back. As Janelle mentioned, we did give a talk, maybe more detailed talk last time than we'll have this time, but we gave some information last time, and we maybe shortchanged the questions a little bit, but we ended up with a lot of questions. So we're circling back for part 2, and then we'll be moving on to other topics in the future as well. Obviously, the corneal issues are very important. Many other issues are very, very important to us all, and we will get to those. But we're just going to try to finish glaucoma because there were just so many questions about it out there. So I'm going to go ahead and share my video. Perfect. So that I can get us started here. And then we'll get going on to this on the talk. And I think I'm just going to share that one, and then do that. So I hope that's showing up on the screens. Janelle, are we a go there with the slides?
We are a go. I can see them.
Okay, great. Well, yes, I have no financial interest to disclose, and yes, this is part 2, glaucoma and aniridia, for the focal point. So I commented briefly on this, but we did cover many basics: rule of eye pressure, some of the clinical findings, the fact that it's a silent disease, can be very asymptomatic, goals of the treatment, measuring intraocular pressure, imaging and visual field testing, the mechanisms of glaucoma, and even examinations in clinic and under anesthesia. So we talked about a lot of topics last time. We won't really be going over those topics again in detail. We may hit on them in the questions, but we won't be going over those in detail with the slides. But I did want to show a few key points that we had touched on last time about glaucoma and aniridia, and then we can focus most of our time on Q&A for this session. So yes, it is glaucoma is a major health concern. Glaucoma is potentially vision threatening, and treatments for glaucoma are effective. So we do like to identify the patients because we can use treatments that will control it. And it is common in aniridia, and you'll see some numbers on that in just a moment. It oftentimes occurs in childhood, which makes it another important point to keep in mind for aniridia. We do want to catch it early and prevent the vision loss because it can be a relatively common of irreversible vision loss in aniridia patients. So we want to try to identify that as early as we can. And we did talk about the mechanisms a little last time, just to emphasize the main conclusion from all that. The most common form of glaucoma, you may have heard of open and closed angle glaucoma, is the most common form of glaucoma in aniridia is the open angle glaucoma. There have been some closed angle mechanisms postulated in the past, but some recent work has shown that some of that, most of that was due to surgery, because it is known that in aniridia, if you do have some surgical procedures, you can get a secondary angle closure after these surgeries. But the most common type, if there's no prior surgery, is just an open angle glaucoma. That has implications for research and clinical care. So I just wanted to kind of get that right out front here. It is common. This is from a survey we did some years ago, and found that about half of the patients with aniridia, approximately half, do develop glaucoma at some point. And the median age of diagnosis is 8.5 years. What that means is that half of the individuals with aniridia who do develop glaucoma, which is overall a little more than half of the total group, those will develop glaucoma early, with half of the individuals who do develop glaucoma developing glaucoma by 8.5 years. So it is something that does happen often during childhood. The treatment is, well, the majority of patients that I see are treated with glaucoma medications. And also the majority are treated with surgery at some point as well. So the fact is that many people have had some kind of surgery and also have some additional kind of glaucoma medication, sometimes even to control the pressures adequately. So the glaucoma treatments do usually involve medical treatment and incisional surgery. That's why I gave those two numbers just a moment ago. Laser, I left out that category because it's usually not very helpful. In fact, we do have some lasers that can help, but the standard lasers that we use for adult glaucomas are oftentimes not very useful. So we do end up focusing a lot on drops or medical therapy and incisional surgery for many of the patients. Surgical treatment is sometimes required to control the pressure, intraocular pressure, over the longer term. And we do have a lot of options. Some people ask me if they can just, if they have the one treatment and it doesn't work very well, I guess that's it, right? Then they're done. Well, the fact is we have many types of procedures. We have many things that we can do as secondary procedures that are actually well suited for that, and then many other alternatives. So there's plenty of options. And one of the key things that we will probably talk about in the question and answer session is that over time, some of the best, most effective pathways, least side effects, are determined through clinical care, and that's true for individuals affected with aniridia as well as other patients too. So we do have certain things that we go to more commonly, and we have many options. The exact choice of procedure depends on the specific clinical problems of the individual patient. It does vary, in other words. So surgery, more popularly in the past, the trabeculectomy was done. It's making an opening in the sclera to let the fluid out, let the fluid out of the eye, drains around the eye. It's just a simple opening. That's not so popular now. It's being slowly, well, relatively rapidly in recent years being replaced, and I'll touch on that here in a moment. Glaucoma drainage implants are still very popular. It's a very effective way to go, and many individuals with aniridia do have drainage implants at some point. Cyclodestructive procedures is a form of laser, but that is oftentimes used after drainage implants as sort of an adjunctive therapy. It does reduce the flow of fluid into the eye. So if you use the faucet analogy, it's kind of like turning down the faucet, whereas the drainage implant with a tube would be putting in a new drain and increasing the outflow through the new drain. So different type of mechanism, but sometimes it's useful to use. And we have many other procedures as well here. I did mention the minimally invasive glaucoma surgery, and that is becoming evident that is helpful, especially the transscleral MIGS. We have the Zen implant and the PreserFlow, and those are easier to recover from than trabeculectomy, safer, and minimally invasive. And so these are tremendous patient satisfiers and also doctor satisfiers because patients do usually well with these. So that's becoming popular. And then, of course, we've had other procedures too. I won't go into detail, but goniotomy and trabeculotomy, this may come up in the question and answer session, has been popular in the past. It's not quite as helpful. It does do some incisions in the angle where the drainage part of the eye is. So sometimes, though, there can be some scarring, particularly in aniridia because it's a pro-fibrotic syndrome. So in other words, there's a tendency towards scarring of those kind of things. And so, maybe that's not the best approach for most patients. And we can talk about all those topics during the Q&A, but I just wanted to give a few comments just to kind of get us oriented into some of the specific challenges that are related to aniridia and glaucoma. And so to summarize some of those points, aniridia is oftentimes associated with glaucoma, potentially causing a progressive vision loss. We like to catch it before then, right? Patients often require surgical treatments, which generally have good outcomes. And then monitoring and prompt treatment can prevent vision loss due to glaucoma and aniridia. And that's the idea of having those childhood examinations where we try to pick it up during that time when the onset of glaucoma may be common. And a key point there is a negative exam early on doesn't necessarily mean that individual may not develop glaucoma later. So somebody may come in at age 5 and they look great, no glaucoma, optic nerve looks great, the pressure is wonderful. And then the challenge is we have to maintain our enthusiasm for the follow-up, especially during that period, because they may come in at age and they may have a little bit of an increased pressure or maybe some optic nerve changes. So we do want to catch those. As I mentioned before, we like to do 6-month intervals. We don't have a full year go with the high pressures. So those are things that we just need to keep up the energy on and try to maintain the enthusiasm for checking on it during that really important period. And the new surgical procedures and medical treatments are very promising. There's many things that are being looked at now that are not ready for clinical care yet, but are being developed for that. And there's a lot of excitement around that. I think it's not only the glaucoma, but also for the keratopathy and other things. You'll be hearing about those in future focal points. But for glaucoma, we are looking at new surgical treatments, medical treatments. We're not trialing anything right now, but we frequently do. And so that's something also that we're always on the lookout for. And there have been many advances in recent years. So I'd like to thank ANA for hosting this focal point. And also Aniridic Family, IWSA, International Wagner Syndrome Association, and also Vision for Tomorrow. Aniridia Europe has been a great partner for us, and we're appreciative to them. And most of all to me, all the patients that I see and their families and all of my collaborators who work together to provide clinical care and try to do some other research that can hopefully positively impact the lives of aniridic individuals and also those who care about them. So thanks very much for having me. And we're going to open it up now. I'm going to turn it back over to Janelle. She's going to step us through some questions. Some of them are from before, but we also want to try to field the questions that you have. So pop those into the chat and we'll get to hopefully all of them tonight. So thanks for being here. We appreciate it.
Thank you, Dr. Netland. As he mentioned, I actually have something like 4 pages of questions here written out for us to go through. But as you are listening, if you have additional questions that you want us to address, please feel free to put them in the chat. We'll do our best to monitor that, and we're going to answer as many as we can. If we don't make it to everything, please know that we will find a way to address it, or at least do our best to address it at some point in the future. So let's start with a very practical question, Dr. Netland. Anna in Colorado wanted to know, does being in the sunlight all day affect glaucoma at all?
Well, it's a great question. There are some things that might affect glaucoma, but the sunlight itself is not known to directly affect the risk of glaucoma. So I would say that it is safe in that sense. There are some other thoughts about maybe effects of sunlight in the retina or other areas in the eye, but for the glaucoma part, it doesn't seem to affect the risk. So we don't discourage or encourage necessarily. We're sort of neutral on that. on that topic about sunlight, because we feel like it's not too much of a risk factor for damage from glaucoma.
Okay, excellent. So if we have a young one with aniridia, what symptoms might a parent notice that would warrant a call to the doctor, particularly worrying about like pressures increasing?
Yeah, I think anything that well, first of all, things that, first of all, trust your intuition. And, if you feel like something isn't right, or there is a change and you're not even sure what it is, try to think through that and collect more observations and see if you can kind of pin down your intuition a little bit, because I've found that intuition is, and a sense that something isn't right is usually important. But having said that, anything that's obvious, like with the eyes, so redness, or tearing, unusual sensitivity to light, that's a hard one with aniridia. But something that just seems to you to be out of the range of normal is important to pick up on. And then some of the things that are asymptomatic, so in other words, any symptoms that might be unusual, a lot of times we'll get some common problems that are like viral syndromes, things like that, where there's redness of the eye. Well, it's not from the aniridia, it's just a viral syndrome or something, but sometimes it isn't. Sometimes it's related to these topics we're talking about today. So always important to kind of trust your instincts and follow up on things where there's acute symptoms. But the other thing to watch out for is if there's things that are asymptomatic. So you might have something where, you're observing, let's say you're a parent and you're observing a child, that situation. So you might see something, where you say, well, I thought, they were always pretty good at doing that in the past, or they were always pretty good at seeing these objects or doing that, or they had certain visual capabilities that you were pretty confident that they were able to, the tasks that they were able to do. And if there's a change there, then that might be worth giving a call about as well, because some of the times the asymptomatic things can be useful to follow up on as well. So I think anything that basically seems out of the ordinary is always worth always worth a call to find out if there's anything that might require a visit.
Okay, that makes sense. All right, so what is your opinion on using, say, the eye care at home to monitor pressures in between appointments?
Well, you'll hear different feedback about this, and I think I'm pretty average, so this is probably pretty standard. I think it's good. I'm good. I'm good with it. I like it because we get a lot of information, and
Mhm.
I think information is always helpful. I see different extremes. I see some that take 500 pressure measurements during the day, and others that don't do that. So you may not need 500 measurements, but every once in a while, it's not a bad idea. Even once a day is not a bad idea. Or sometimes if you want to do a diurnal curve, that's not a bad idea. Check it at different times of the day. The challenge, of course, is getting the device at home. It's expensive, and some of the physicians will kind of rent it out of their office, you might say, so to speak. They might even charge a little bit for using it for a period of time, and even that can be useful. But ideally, of course, you want to have it at home with you all the time. You never know when we might want to check it, and sometimes you want to check it regularly. So it's always a good thing, in my view, to have one. The one that's useful for home use is the rebound tonometer. There is a home tonometry device, and it is a significant expense. Sometimes I've heard that some people can get some assistance in getting those through insurance and other things, but generally it's an uphill battle there. But it is an expense. But if you have it, it's and the tips have to be replaced. But if you have it, it can provide some really useful information. And so I'm kind of in favor of it. The nice thing about it is that it does measure. You can measure the eye pressure without anesthetic, and that's the key advance for the rebound tonometer, is you don't have to put in anesthetic drops, which can have a very significant downside. We can have corneal problems from that. So we do like to avoid that, and the rebound tonometer does do that, so it's great. It's excellent in that respect. And the other thing is you have to get some tips. So the tips need to be replaced. Okay, I'm going to say something that may be on this a little bit of a side point, but those are supposed to be thrown away every day, but they're like about $1 a piece. So some people do white them with a little alcohol and then reuse them. I'm not supposed to recommend that, but
So speaking of home pressure monitoring, are there any developments out there that might be better home pressure monitoring coming up, like easier, cheaper, anything like that?
There's yes, there. I think that's an area where there hasn't been as much response with products as I would have thought,
Okay,
because there's a huge demand for it. So I think we have a one or two things that are out there, but I think the future is looking positive in the sense that there is a market. It's pretty strong. I think right now the price point is pretty high, and obviously there is enough demand to try to hopefully get that down. And there are some other novel approaches too. We could talk about this along with some of the corneal issues that come up, but I'll just mention it now. There are some other ways of measuring the pressure that are looking pretty interesting and pretty helpful. We are looking at the diatom tonometer right now, which measures on the sclera. And so there's some other ways to measure the pressure, which may be helpful. There was a through the lid monitoring device, which again could be used with anesthetic. We found it to be a little bit less accurate, but so we don't use that one regularly, but we're looking at some of them that are the non-corneal measurements. And there is some promise there too. And those would be excellent for home use. The through the lid one was really thought wonderful in terms of, for home tonometry, because you don't need
right.
anesthetic. It's great. The problem was accuracy. It wasn't super accurate, but so the ideal combination is not quite there yet, but the rebound is pretty close. And hopefully there will be more competition where we can get some more devices out there, because it's a pretty limited choice right now.
Okay.
With the market for that, there should be more products available in the future.
Okay. Diana from Alabama asked, is it okay to measure the eye pressure of an infant at home using something like an eye care?
Okay, I'm gonna step out there too. I can't think of a downside, so
Okay.
I'm gonna say that that's okay. The infant eye pressures are a little bit lower on average than adults. The pressures do slowly rise over time, so we have the expectation will be around 10 or something like that. Whereas an adult, it might be mid-teens on average. I think 16 is the average
Okay.
intraocular pressure out there in the general population. And there's a standard deviation of 2.5. So that's why they say that the normal range is up to 21, because that's 2 standard deviations above normal. So it's a little bit lower in infants. It should be anyway. And so even if you get a little bit of a higher pressure reading, then maybe pay attention to that. The rebound you have to have, it's better. It does have a magnet, so it won't drop if you take the pressure with the child supine, laying down. You can do that, but we recommend try to sit them up, because and also distracting them with something, because if you don't press on the eyes and open the eyes forcefully, manually, and stuff like that, it'll give you a better pressure reading. And you'd be surprised at how you can do that in a child who's awake but comfortable and happy with a bottle or something. So, but sitting up is ideal, because then the tonometer doesn't have the tip held by the magnet. It's a little bit more stable, and it gives a little bit better reading. So there's some little tips on that you can get from your doctor, but I do think it's, to my view, it's acceptable. I've not seen any parents injure their child with the tonometer. So I think we're okay with that. And if I hear something bad about that, I'll change my recommendation, but so far, so good.
Perfect. So speaking of that, you mentioned that, depending on how you do it, it can impact the pressure reading, right? Like if you're, really holding it open or whatever. What are the best conditions for taking pressures to ensure that the reading isn't falsely elevated when you're with an ophthalmologist?
Yeah, that's really a challenge. So for us, we see this all the time. Even with new technicians, we're trying to delegate sometimes the readings to techs or to young doctors who are learning it for the first time. They have to learn some subtle things, but I can just summarize them in a couple of words. I think we try to get people comfortable. First of all, if you're straining, holding your breath, the pressures will be artifactually elevated. So we do like people to be comfortable. If they're getting an applanation tonometry measure, which is a blue light, they should be sitting comfortably, leaning forward a little bit, but not too much, not hunched down too much or not too high or whatever, just in a comfortable position. And the other thing is that you shouldn't put pressure on the eyes. So if you do need to, you can press against the bones up here, whatever, but you can't press on the eye while you're reading it, because that'll raise the, give you an artifact as well. And then the final one that's really, really tough is a lot of squeezing and fighting. So if you have a child and they really don't want you to measure the eye pressure measurement, it's tempting. I've got 4 kids, so I can tell it's tempting to hold them there and just like make them do the pressure reading, but it's kind of counterproductive, because a lot of times you'll get a high reading and then you're not sure what to do with it, because they're just squeezing, fighting, straining, holding their breath, or screaming, which also raises their eye pressure. So any of those things are not good. So you try to get people comfortable so that they're relaxed, they're not squeezing their eye. And those are the main points. And I leave it, every situation is different. So I'm going to leave it to you all to decide how to do that.
Yeah, each child certainly, or even adult, I would imagine, is different in that regard, right? What makes them feel comfortable.
Right.
So you mentioned measuring throughout the day. Is it possible that like afternoon and evening your pressures are always good, but there may be a little high in the morning, like if you were again measuring at home?
Right. So that is a really good point and a big topic because there is a diurnal fluctuation in the intraocular pressure measurements. In an average person, it's probably sort of 4 or 5, even up to like that. In glaucoma, the range of low to high is greater. So we can see 10, even 15 millimeters during a day. So I think it's sometimes if you get some high readings at certain times of the day, it can be a sign of maybe the glaucoma is developing, or maybe it's something, getting more variability. Sometimes it's just the variability of the way you take the measurement. But I do think that that it's important to keep in mind there is a diurnal variation. We should think that it was more high in the morning, after people wake up, because there is a lot of evidence that for their sitting up, standing up, or sitting up, or moving around, position, which they're doing during the day, pressures are a little bit higher in the morning on average.
Okay.
The new twist on that is that supine measurements are actually a little bit higher because for some reason, when we lie down, our venous pressure goes up and in our head and other things. Right now, venous pressure, if I'm sitting up like this, the venous pressure is pretty low, but it goes up a little bit if you lie down, and other factors come into play. And so if you actually measure the eye pressure with a device that will measure supine or sitting up, you find that the pressure readings at night are sometimes higher.
Okay.
So it's a very interesting topic. In the old days, if we did a diurnal curve 24 hours, we would actually wake people up, sit them up for a second, do the reading at 1 in the morning or whatever it was, 2 in the morning. This is one of the great things I did as a young physician, but I had to do
That had to be fun.
Oh, it was awesome. Yeah. So we would, wake people up, get them up, sit them up, and then we would, measure the eye pressure, and then that was it. But now we have devices that we can measure with people laying down. We don't get them up. And so we find out what their real pressures are in their real positions all the time. And it is interesting that it's a little higher sometimes at night. So getting a sense of those variations is good. It can tell you, it can be revealing, and helpful to know when your higher pressures are. And for us, we use it mainly to find out if we're really controlling the pressure. We're not sure if fluctuations are really, really important for damage, or if it's just the average pressure that we can pick up in the office. But it is clear that we miss a lot of peaks just in our office readings.
Okay.
And the significance of that is still debated a little bit, but it is thought that if you have pretty high fluctuations and higher peaks, then that may be significant for glaucoma progression. Certainly, if somebody has a lot of damage already, it's probably not good to have really high peaks. But for others, it's of uncertain significance. So if you have a normal person and you have a pretty high peak every once in a while during the day, let's say you're coughing a bunch, or you do something or you're playing a trumpet or something, and the pressure goes up to weightlifting, temporarily goes up from a higher venous pressure or whatever it is, those fluctuations, or you rub your eye for a second, those fluctations are of uncertain significance in the sense that they do not seem to cause damage in normal people. But in glaucoma, if somebody has glaucoma, they are something to think about. There has been a fair amount of evidence that those kind of things can lead to some progression.
Okay. Let's move into the concept of prevention. I think last time when we talked, you said there really wasn't a lot we could do to prevent it. There wasn't a lot lifestyle wise or anything like that we could do. I know there have been a couple of people that have had their doctors suggest either a preventative goniotomy, which you mentioned is not such a great plan. Somebody else had recommended to them that their lenses be removed to prevent glaucoma. Can you address that in the goniotomies, if any of that prevention is a good idea?
Okay, I'm going to take that as a two-part question, Janelle. Sorry, but I'm going to answer those two things a little bit separately.
Sure.
I'm going to slightly modify what I said before. I'm not going to say I'm going to retract it, but I'm going to modify it a little bit. So are there things you can do? In other words, are there modifiable risk factors, we call them, things that you can do and modify your behavior to mitigate, improve something to affect the progression of glaucoma if you have glaucoma? And the answer to that is there are some at least two known risk
Okay.
factors or that are, modifiable risk factors that we can modify. And they're not things like with blood pressure where salt, or drinking coffee or something. Those things have been found to have very little effect on eye pressure, diet things. But I can tell you there's a couple things that have been found to be have some effect on pressures, and they're very interesting. One of them is just mild exercise. And that has been shown to, it's not very much, but it's been shown to have a consistent 1 to 2 millimeter lowering effect on the eye pressure. And we're talking about just, walking 3 or 4 times a week, maybe a mile or something. I don't know. Not very much exercise, but a little bit of exercise can help. And the second one is really interesting to me because finally we've had a chance to study it over the last couple of years in a way that really can determine what the effect is. We've always had suspected that stress is kind of, maybe a bad thing for people. It is bad in many ways, but it's always been kind of suspected that glaucoma might be affected by it, but we didn't really have any evidence for that. But now the last couple of years, we're getting quite a bit of evidence. And the key thing that happened was that there was a way that was found to induce stress in people that where you could measure that the blood cortisol levels changed and they were really under stress. And you could then determine and you could reverse that. And I'll
Okay.
tell you what that was. It's kind of interesting. It was public speaking. So it's kind of like what I'm doing right now, right? They gave people in another country, this is not in the United States, but they gave people a job interview. They said they advertised a job, they brought them in. They said, you have to give a talk to get this job. And so they did the talk and then they measured all their cortisol and stuff and did a bunch of stuff. And they determined that they were under stress. They felt stressed out by public speaking. And that led to a consistent 1 to 2 millimeter rise of the intraocular pressure. So sort of like exercise.
Okay.
So you can, and then they found that meditation, mindfulness meditation specifically did reverse that 1 to 2 millimeter rise. So stress, we now know actually can do it. I've had patients come in to me after their house burned down and stuff like literally, I'm not kidding.
Oh my.
And they seem to be indifferent to it, and I'm not sure it affected their eye pressure, but people vary their response to stress.
Sure.
But if you
Sure.
do have stress, then that can be a factor too. So that's the first part of the answer is that I'm going to say there are some things that you can do. They're very small effects, a couple millimeters, but some people on the fence, it might help them a little bit, and just something to keep in mind there. The second part of it is the let's see,
Preventative goniotomies or removing lenses.
preventative goniotomies we don't recommend now. We have a lot more information about that over the years. First of all, it's thought to maybe lead to the scarring down in the angle and actually be counterproductive. So there's a lot of things that we don't recommend where we say, where we do recommend, where we say we hope it will help. It might give a little bit of a benefit, but there's not going to be a downside. We'll be able to move on to the next thing if we have to. And, we hope it helps because then it'll save you from going on to the bigger things, but, it's not going to hurt you. The problem with goniotomies is it may push the pressure up and it may lead to some scarring in the angle. And that's why we're not recommending it really right now. We also have a lot of evidence now with adult goniotomies that I've tracked back with the more modern techniques of things like the Cahook dual blade, the KDB blade with the more MIG style goniotomy procedures. And those are also not effective. I saw no lowering of the eye pressure in Aniridia patients at all. So I think that the challenge there is that, and that supposedly doesn't have as much scarring because you remove all that tissue, but it probably does. So I think, that because it's profibrotic syndrome, we see some scarring after these treatments in an area where you can't afford to have scarring because it's where the drain is. So I think the challenge on the goniotomy is that as a treatment approach, it's not effective. As a prophylactic approach, it may lead to worsening of the angle closure. And then the more modern variations of it don't seem to be any better. So I think we're kind of trying to move away from that right now at this particular time. We may maybe there will be some advances that'll help us revisit it because it is nice in the sense that it's not very invasive, but
Right.
it just doesn't seem to help right now.
Okay. So what is the best way of measuring and treating glaucoma in a patient with a corneal prosthesis? Carol from New Jersey asked that.
Okay, I'm gonna double back here and ask you to on the question. I caught the keratoprosthesis. Are we saying what is the best way to measure the pressure or to do
Yeah,
or
measure and treat the glaucoma. So measuring the pressure if you've got a corneal prosthesis.
Okay, I love that question. I'll tell you why, because the guy that developed that keratoprosthesis, the one that's approved in the United States, I worked with him for several years and I did the first 3 times he ever used it with him. I did the couple of those series, and we published papers about it.
Wow.
So the story was that, he had developed the keratoprosthesis, Dr. Dolman. It's called the Dolman keratoprosthesis. So he did a bunch of eyes, 50 eyes, I think it was, and they all failed the first time because of scleral melting. He fixed that by covering up the eye with conjunctiva and then opening it up later. But then all of those failed because of glaucoma. 100% of those patients develop glaucoma. Severe surface disease causes glaucoma. So the patients did not do well in that series. So the third series I helped them on, and we actually put in the tubes, drainage implant tubes in that series at the time of surgery or shortly thereafter. And that did correct it, and finally was able to achieve success. So that's how the Dolman keratoprosthesis evolved, was that the glaucoma was a very significant impediment to success for that device early on, and it was overcome by using the drainage implant approach during the surgery. And now secondary procedures are the laser, the cyclophotocoagulation. So those are now helpful. But then part of the challenges during that time is we had to figure out how to measure the eye pressure. That was when it was being developed, right? So we also published another paper about how to measure the eye pressure, what things we can do in that. So there's some new devices that are coming out now that are probably better. The diatom is one that we've looked at. That's why we're looking at it, was for keratoprosthesis. The other ones are of interest to us. We can take the rebound off of the sclera. You have to get behind the back plate of the keratoprosthesis, so you have to go a little ways. But we can get some measurements. Some of them are kind of close to being okay. But strangely enough, the most effective way to get an estimation of the eye pressure was to do tactile estimation. And that's why we kind of commonly tell people to feel their eye, and you have to go back past the keratoprosthesis. But if it feels soft, then it's probably okay. If it feels like a rock, then it's probably not okay. We were actually pretty accurate with that. We actually published a paper where we measured how we performed in unknown pressure situations, and we were able to get pretty close, probably within 5 millimeters, after some experience with it. So it was a way to monitor it. It's not great because we don't get a specific number, but we're still working on that. Right now, they're looking at ways to put an implant on the keratoprosthesis, a pressure sensor that can be measured, where the pressure can be transmitted externally, or it can be measured in the office with a device that kind of charges it externally, like those cell phone chargers that don't actually. So like that kind of thing. And so those things are coming, and they may be part of the keratoprosthesis in the future. So there will be essentially a real manometer on them. But right now, we don't have that. And so we have to just make an estimation with tactile estimation normally. Turns out that's pretty good. And then the backup on that is we also look at the optic nerve and the visual fields to see if there's any progression of glaucoma. And then that also tells us whatever the number we think it is probably too high for the back of the eye, and there's some damage occurring. So then we try to treat for that. So we do have techniques and backups, but weirdly enough, it's usually just feeling the eye that we try to do.
Okay. How important is axial length measurement, especially in like a toddler? Mariana from Indonesia wanted to know that. And she's thinking, if both eyes are like borderline, but the axial length is growing bigger than it was before, does that matter?
Yes. So that's a really good point. And hopefully, Mariana, right? Is that? Okay. Hopefully, well, you're going to be like 12 hours off here, right? So it's going to be the exact opposite side of the clock. So hopefully you're on, but yeah, basically, yes, we do follow the axial lengths occasionally, especially when if we're let's say another childhood glaucoma is, let's say in congenital glaucoma, very important, because early on before age 3, if the pressure is increased, the eye will increase in size. So the axial length measurements are not only good for congenital anomalies like macrophthalmia, or for person developing myopia, which is going to enlarge the eye, but really most importantly maybe it's for glaucoma, because if a young person has that and their eye can expand, which would be certainly less than 3 and probably a little bit over 3 too, we do like to monitor that, because it can tell us if the eye is expanding or not. And the measurements, if it's getting bigger and bigger and bigger, then that also would suggest that whatever pressure we're measuring is probably a little bit too high for the child. If it's a macrophthalmia case, it'll stay big. It won't change size.
Right.
If it's myopia, it'll be a little bit of a change, but not much. But if it's congenital glaucoma, you can get quite a bit of enlargement. And I've seen some massively enlarged eyes over my career. But basically, a lot of times, when when we're first doing the exam when it's already enlarged. But if we do have the opportunity to try to do serial ultrasounds, we'll do those, and they're pretty easy to do and can give some good information about that. So I think it's a good idea. It's not the only piece of information, but it's helpful adjunctive information.
Okay. Rachel from New Jersey asked, what variables contribute to an aniridic patient's difficulty with controlling glaucoma just through medication?
Right. That's not a big question. We do have a bunch of medications. It's been estimated that we have about 50,000 combinations of medicines that we can use. Okay.
Wow.
So because there's a whole bunch
That's
of,
a lot.
that's a lot, right? So we're not going to take any patient. Don't worry. We're not going to take any patient and just give them 50,000 different drug combinations because we have certain categories of drugs that we know are additive and certain things that we can combine and certain things that we use. Right now, we're up to about 4 to 5 different categories that we can use. So we'll add one type of drug, might be a variety of different products, and then we'll add another one to it that we know, and that's been proven over hundreds of thousands or millions of patients that it's a good starting, first line drug. And then after that, we go to a second line drug and then a third line drug and a fourth line. So by the time we get to the fifth drug, maybe it has some side effects, or maybe it's not, but it can be effective, or maybe it doesn't have its side effects, but it's not as effective. It's not quite as good as the primary line drug, maybe, but it can add useful lowering of the pressure. So we get up to about 5 drugs or so, 4 to 5 drugs, and then we stop. Now, sometimes we have intolerance to some of those medications and we can't give that many. Aniridia, obviously, you don't want to bathe the eye in a lot of drops that might have toxicities or might have side effects for the cornea. So we have to be cognizant of that. But basically, we can add multiple drugs together if the first one doesn't control it, and then keep adding until we basically run out of categories of drugs. And that would be somewhere between sort of 3 to 5 drops. That's
Okay.
what's going to be maximal medical therapy.
Okay. Okay.
You
So
can't control it with maximal medical therapy, then you got to move on to something, surgical therapy or something else.
then you got to look at surgery. So it's less about a specific number that you're hitting and more about we're not controlling it with drops. That's when you decide it's time.
Great point. And so, and that evidence has to be for a couple of things. So the number itself is challenging, and I get a lot of feedback from individuals in Aniridia that say, well, my number was over 21. Well, if the number is 21 and if the measurement is not accurate because the corneal thickness is super huge, the corneal thickness we talked about last time, 12.1, if it's thicker, the cornea tends to be a little bit more rigid, and you tend to measure artifactually high pressures in those situations. So, and the average corneal thickness in Aniridia is over 700. Normal is around 500. So everybody's going to have a little more rigid cornea than normal. And so if that's not taken into account, people can be a little bit too aggressive about that if they just look at the number alone. So the context you want to look at that in is what's happening with the optic nerve, what's happening with the visual fields. Is there damage occurring? Well, okay, then it's time to do something. And I've seen people with the same number, maybe it's 24, 25, that are stable, and then another person will have some progression. So I think, you do have to put it in context of the individual. The number isn't everything, but if you combine that with looking at the nerve tissue and stuff like that, you can usually tell if the situation is not good, and then provide the treatment that's needed.
Okay. How do we know when a drop is not good for our eyes? In other words, like one person asked, oh, with this specific drop, my daughter's eyes seem irritated, smaller, sunken. Is that normal? Is that something I should expect?
Right. It's not normal. And so, normally if there's almost any symptoms, then it means there's some toxicity that's not right. And so they all have different ones. Some of them just cause chemical irritation. They're a little bit acidic or something like that. Some of them cause, almost like an allergy response. And some of them have pretty high rates. One of them has about a 20% rate, 20% rate or so. And that's high. If you had a 1 in 5 chance of winning the lottery, you'd play the lottery every day, right? You
Right.
Wouldn't you? If you had 1 in 5 chance. So you'd do that every day. So that's common. It's a common thing. You don't want to see, the rates are pretty high. So I think, there can be side effects. They have variable reasons, preservatives. Some people have intolerance to that. So there's a lot of different reasons why people get intolerant of medications. And we're almost agnostic about that. If they just develop a side effect where they're having symptoms, we usually try to get off that drop.
Okay.
Most of the side effects are not that good. Now, we have some that are silent that you don't notice that much. And those are the sneaky ones, because we have about half the people may have some irritation on the cornea that we can see that don't have side effects with one of the drugs. So I have to look at it every time, and make sure that they don't have any side effect from the drug. Another one is that one of the drugs causes a little bit of mild kind of opacity in the cornea that is reversible, but
Oh,
if you
okay.
stop it. So we like to pick that up. The person may not notice anything, but we like to look and make sure that they're tolerating well. So we have a couple of those that we have to look for, but for the most part, if you have a side effect, you're usually noticing stuff like that, tearing or there's some symptom. And then that's really important to notify the doctor about, because yeah, usually we have to take the person off that medication and hopefully find something else that can control the pressure as well.
Okay.
And that's the other explanation. Remember, I said there were 50,000 different
Right.
combinations that are possible. That's why I have people that are on 50,000 different combinations, because the efficacy and side effects vary from person to person.
Sure.
So there's no uniform regimen that works for everybody, because some people might have a side effect from one and they might have more efficacy with one than other people. And so that we end up going in that direction and keeping them on that medicine without switching. And so we end up having everybody on millions of different combinations of things because their individual side effects and efficacy varies.
And some people can be on one medicine for years and have it work, right? Some
Exactly.
people can only be on it for a short time and and then nothing's, managing it, right? So it just is very
Absolutely.
varied from each person. All right. Um, if you've been treated for glaucoma for a while, is it something where the pressures can then go down and maybe you can reduce the treatment again, or pretty much once you're on it, you're kind of on it for a long time?
Yeah, I would say the generalization is once you're on it, you're probably on it for a long time. But we do see an occasional person that does get better over time. Obviously, if you have other treatments or substitute something or have a surgery or whatever, you can get off all the drops, sometimes. So it does vary from person to person, but there can be some improvements over time. A good example of that is not so much maybe in aniridia, but let's say somebody's giving a drug, they have a side effect, the pressure goes up, a steroid or something, steroid. And if you stop the steroid, well, maybe they'll need the drug for a while and then you can stop it. I have seen spontaneous improvements in aniridia and other things too, many patients, but the percentage of people like that is relatively small. So, but I do see a lot of people that, if they do have a surgery, they come off the drops altogether. So.
Okay. How long after detecting an elevated pressure does irreversible vision loss occur? In other words, it's happened, right? We've got high pressures. Is there time to go see a second opinion for somebody or something? Can you wait 1 to 2 months, or do we need to do it immediately?
Yeah, that's a really important question. And I do think that there's a level where it is kind of urgent to take care of. So let's say the pressure is 50 or 60, and that doesn't happen very often, but it happens often in other conditions. But so I see that every week, and then we have to do something relatively quickly because for anybody they can have some loss of vision over a relatively short period of time, weeks type of thing. The sneaky ones are ones where there's a little bit of elevation of the pressure, and it's especially sneaky when a person has an increased corneal thickness or some other factors that or they haven't had much damage and they're not sure that that's a significant number or not. And that's where I do think there's ample time to get a second opinion. And I do think it's valuable to try to do that. So it's a really good point because a lot of times you'll feel like there's a lot of pressure to do something really fast. But a lot of times you can get that, you have ample time to get that second opinion and think about it and talk about it. And I hate to see anybody, let's say you're a young adult with aniridia or a parent who has to make a decision for a child. It's really difficult and it's super stressful. I hate to see them rushing through that decision. So I do think that there's almost always time. If the pressure is extremely high, which is not super common, then that time may be much shorter.
Okay.
And it's a little bit of an experience thing to know where that threshold is. But I will tell you that there are little charts from studies that say if somebody has a pressure of 50, they got to do something by this amount of time.
Okay.
Let's say if they have sickle cell anemia, they might have to do it even shorter because they can have circulation problems with the pressure or the drugs that are used to treat the patients. But anyway, basically there's a whole bunch of different ways to analyze that. Much analysis has been done. And it goes just sort of like that. If it's super high, then obviously we have shorter time. But if it's a mild elevation, it's surprising how much time you have, especially when there's not any damage already. There's
Okay.
no damage that has been detectable. Then you almost always have time to get a second opinion. I think it's extremely valuable. So I know I've rambled a bit on that answer, but I do think that that's a really important question, and I hope that's answered it.
I think
Is-
it did.
okay.
Um, because obviously once vision loss occurs with glaucoma, it is not reversible, correct?
Nobody wants that, and we don't either. So I think, but I do think there's a lot of times I see a lot of folks that do have time to get it,
Okay.
and especially with those pressures in the 20s and things like that. No damage. You got time.
Okay. Speaking of surgeries, I have a whole list of questions about surgeries here, and some of them you already answered, that really the right question or the right surgery is going to depend on the clinical situation. So you can't just stand here and tell me, oh, this is always the right surgery. We did have a couple questions in the chat. One from Kelly in North Carolina said, do tube shunts have to be redone after you already had the surgery once?
Ideally, no. It can be effective as a single treatment, but sometimes there's a bell curve like everything. There can be some people that encapsulate around the plate pretty significantly, and so there's a lot of resistance to flow. Then their pressures may go up. There's a lot of solutions to that. One of them is that some people will put in a second implant that has about a 60% success rate. Other people will do an adjunctive treatment with a laser that has a 6-7, a little bit higher percent success rate, actually about 70%. So there's different approaches to that, but and then in some rare cases, you can actually remove that capsule and then let it reheal again if there's some reason why I think it'll heal up better.
Okay.
Not usually a good strategy in Aniridia, but in other words, there's multiple different options there. I don't think it requires another treatment if the pressure goes up when there's already an implant in there. But it does require a very thoughtful analysis of why that is, and then understanding what the next step would be. There's a large literature on that.
Okay.
And I think there are logical steps. For us, I would say most commonly we do a laser to help with that situation if the pressures go up a little bit. But yes, I mean, we ideally want to have that be a successful treatment. This is a single treatment. And I think we do see some 2 implant situations, but pretty rare. You're putting in more and more hardware, and there's a lot of clinicians that will avoid that at almost all costs. They'll do other treatments rather than putting in additional tubes. So it's a complicated topic, but I would say the answer is no. You don't have to really in any situation.
Okay. Speaking of laser, you mentioned that. Is the MPTCP considered minimally invasive? Like, is that safe to do a couple times a year for a toddler to hold off on a tube shunt?
Yeah. Okay. So that's another great question. So yeah, I think it is. It's relatively safe. Okay, it's non-invasive. It is relatively safe, but it's not totally safe. And in fact, if it's used as a single treatment, there's a pretty large amount of literature about that too, and it has some very significant side effects that are related to including vision loss and even shrinkage of the eye, too soft of a pressure. Because the problem there is if your drain is not going at all, let's say the sink is completely clogged, and you're relying on turning down the faucet, you have to get the faucet to near zero or zero if there's zero drainage. And so if you get the situation where there's zero drainage, you haven't corrected that, and you're turning the faucet down to zero, okay, you can imagine that's not ideal, right?
Right.
So you want to just, get more drainage so that you can make it more physiologic and more normal to, of a situation. So I think that's a great question because, some people do temporize by doing that. And I will say we do it occasionally. We just had a discussion about a patient today, a different problem that we were considering these various options to kind of get us through next week, because this person was going on a trip to Mexico and it had a pressure of 50, right? So we had to try to, and they wouldn't change their travel plans. So we're trying to figure out, how to do this, and do we temporize and do something really quick and then do take care of them when they get back, or what do we do?
Okay.
So I can't say that we figured that out yet because we're still talking to the patient, but basically sometimes it is good to temporize, and sometimes if you temporize, you're expecting it to get better, but the problem is it may not get better. So I think the challenge with that strategy is eventually you run out of times when you want to keep doing that. And what is that number? Nobody knows exactly, but it's not forever.
Okay.
It's not a forever.
And then Elena asked, what about viscocanalostomy as a procedure?
Yeah, I mean, it's reasonable. You're getting into the angle procedures again, and all the challenges with trabeculotomy and goniotomy. The viscocanalostomy is a similar deal. It might open up the inside things a little bit less traumatically. Maybe it's okay. It has not been studied with literature and it results in aniridia, but it's not necessarily a harmful thing to try. But the problem is you're getting into that goniotomy area where you're treating that part of the eye, and if there's no evidence, we obviously optimistically hope it would be helpful, but we don't know. And it could be like goniotomy where, it scars, makes some more scarring. So.
Okay, let's move on to working with doctors, because this is an important topic, right? What are questions that I should be asking my physician about managing glaucoma in aniridia?
Right. I think it varies with the age. So young child, obviously you've got some time. They're not measuring the vision very accurately, but they are trying to follow the optic nerve, and they're trying to see the pressures. They're trying to get a pressure somehow during the clinic visit. They don't like to do EUAs because repeated EUAs are now not the ideal thing because of the repeated anesthesias. So, we're trying to do everything in clinic. We want to get a pressure. We want to go look at the nerve, and we can't measure visual fields accurately until kids now are, I wrote a paper about that literature that showed that it was about 10, but now that's moved up because everybody's on video games. They know how to do it. So maybe 8 or 7 or 8 like that. We can't really do good visual fields. So I think the things you want to ask about are the optic, is the eye healthy? Is the optic nerve healthy? The things that we have a risk for, is the cornea healthy? Because that's sometimes showing up a little bit early. And you can always get a look at that with a little portable slit lamp. So there's no time, you should never not know the answer to that if you're a doctor. And the optic nerve should be healthy too. And ideally, the pressure should be measured, and then that should be normal as well. So there's a couple of key things you want to get from the exam that are targeted to the things that individuals with aniridia can have. And those are some of the questions you can ask. The other thing is that what are things that the doctor is concerned about? Are they monitoring things that they're feeling are maybe things that are borderline that they want to be following and make sure it's okay? So those are things that are important too. And then sometimes the bigger plan is important too. If there is a problem, what is the plan on that? And, are you thinking, well, we're going to start with some drops and then maybe move, see how that goes and which specific drops and why and things like that. If the surface is having some problem, what is the plan on that? So I think you want to get some idea of the assessment of what are the problems, and then some of the plan for how that's going to be managed. And those are very important things. So I think you shouldn't really ever feel like you go to the doctor's office and you walk out and there's just no information that you're getting at all. I feel like there should be a little bit of communication about those kind of things. What are the problems? What's being done? If things do look good, what things were checked to make sure that we are okay? And I also feel like, parents and family members in general should always be able to speak about other concerns too, like the vision, the refraction, do I need new glasses? I mean, just really silly things. Everything is important. And if you have some questions, kind of write them down ahead of time. This is, you hear this advice all the time, but it's really good advice. Write down the questions ahead of time so you don't forget them. And then when you go in, just ask your questions, because, if they don't want to answer your questions, then that's not right. You have to be able to get some answers.
I was going to say that leads into my next question, and we really only have a few minutes left, Dr. Netland, but I still have like a page and a half of questions, so we're going to speed through as many as we can in the next couple of minutes. How do you know when it's time to find a new doctor? And you kind of just summed that up a little bit.
I'm going
right?
to leave it on that. If you feel like the communication isn't good, or also you're concerned about the care, it is time to move on. And then that's a challenge. Moving on, network, and also look for institutions that are reputable. And things like that. We had a question, I think, at one point about the Northeast and so forth. I think in those areas there are some very reputable institutions. Good place to start, and also word of mouth is good. Try to find doctors that can be a better match if it's not feeling like a good match.
Yeah, like you said, finding a good institution that has all the specialties is always a good place to start. Okay, let's see how many more we can get through. Can you address aniridic fibrosis syndrome? How common is it following glaucoma surgery?
Yeah, the literature is about 4% of after 4% of surgeries, we'll see it. Now, that number again sounds small, but it's actually a big number. 4% is pretty high. In other words, it can happen to you. So we are concerned about it. The actual number may be higher for certain procedures than others, but the exact risk factors aren't known. But generally speaking, things in the angle and the cornea of the eye there seem to be a place where it can start, and those kind of procedures can be problematic. So I think that it's a challenge. Also, the treatment is very difficult. It's hard to reverse, and there's only literally a few people in the United States that will do that. Okay. So it's a difficult problem. We take every measure to try to avoid that, because it's a challenge if it ever occurs. Okay.
What makes, do the phosphates and the preservatives and the drops, can they contribute to keratopathy? Can they make the eyes more dry? Can that be an issue in
Yeah,
aniridia?
phosphates is an interesting one because there's a balance, right? Too much of it, I guess, or too little. So it's one of those things that has to be balanced. I don't think in the right proportions it's necessarily harmful. There is a lot of drops though that do have toxicities, have to be aware of them, preservatives.
Mhm.
Other drops are just a bit acidic. And so there are things in drops that can be an issue. But that's all a very controversial area because in aniridia, we don't know if they're particularly sensitive to some of those things with the keratopathy, or if you're just going to get the same amount of keratopathy anyway.
Right.
So I always think it's a challenge with the glaucoma drops because every cornea specialist I ever talk to says that everything all the drops are bad. And then the glaucoma people think that none of the drops are bad for the cornea. So it's a challenge there. I think it's hard sometimes to prove that it's related. But some of the things I do accept, like the really acidic drops, okay, they may have some irritating effects. And then the preservatives, some people do have sensitivities to those, and some people have real allergies to the drops. So those
Okay.
are things that we do watch out for.
I did want to mention that there were a couple of questions that were submitted, both in the chat, one from Irma here in the chat, and a few via registration that talked more about things like the cornea, what can be helpful for corneal keratopathy. And I wanted to mention that we are hoping to have a focal point entirely about the cornea sometime this year. We're kind of in the beginning stages of trying to think through that. So we may hold off on addressing the cornea questions until we have a corneal specialist in front of us. So Irma, I'm sorry, we're probably not going to address that one tonight, because we'll let a corneal person talk about that. Would you agree, Dr. Netland?
Yeah, super important area. A lot of exciting things going on now in research. That's a hot area for us in glaucoma. We're looking at MIGS, minimally invasive glaucoma. That's our hot area right now, and I'm doing on that with Aniridia. Look at the Aniridia Europe website. They have in our website, ANA website. We have recordings of the talks from Aniridia Europe where I did focus on MIGS and Aniridia patients. But cornea is extremely active because that's a big problem. It's going to be one thing we have to focus on to really overcome.
I really feel like the whole topic of the cornea could be 3 or 4 focal points. There's so many avenues of research going on. There's so much to discuss. It's such a multifaceted situation that we'll definitely need to hit on that pretty hard. So let's leave off with a question. You mentioned MIGS, but a number of people asked, Natalie, Kay, Lindsay, Diana, about research. Like, where do you see it in the next 5 years? What are the current research efforts for treating glaucoma and aniridia? What are you seeing that might be new and upcoming?
Yeah, just well, I think the cornea is a really hot area, but in glaucoma, I'm focusing on MIGS for my research right now because I think that's an area that's very helpful to people to have less side effects and same efficacy kind of thing. So we're looking at that really a lot, and I think we're avoiding the angle surgery with MIGS and focusing on the transscleral MIGS right now, and I think those are really working well. We also have a lot of medications that are coming along in glaucoma. They're a little bit early in the pipeline, but we have them every year or two. There's a new medication. So right now the drug delivery mechanisms are being focused on more. How do we do things where we can have less drops put in the eye? There are various injectable, slow release formulations that we are looking at. One of them is out, but we're not sure it has universal applicability for aniridia. But we're looking at a lot of drug delivery things for medications. And some new categories are coming, but not being trialed right now. But the surgery is extremely active, and that will lead. It has already led to some improvements, and will continue to lead to some improvements there. Diagnostics, of course, super important, but we have some great tools there. I think the pressure readings, we could do better in aniridia, so we're working on. Those are being modified slowly over time. But I would say that right now the treatments are really a focus area for a lot of the research going on now in glaucoma.
That's great, Dr. Netland. So I wanted to let people know that that's probably about all the time that we have. I think we've covered most of the questions, at least a little bit. And as I look through it, if there's something I missed, then I will. Oh, there was one other one, Dr. Netland.
Yeah.
Can the drops, or can any of the drops, cause cataracts to become more prominent, or cause issues with the lens?
Yeah. And kind of related question, I wanted to say quick answer. No, removing the lens usually doesn't help the glaucoma. So it's not known to do that. It is maybe some things, but not aniridia. So so I think and then as far as drops that might have caused the cataract or make it worse. No, we're not convinced that there is anything that's doing that. But I will comment that there is a slow change in cataract that happens with any kind of eye disease that one has. If there's a disease or if there's treatments or almost anything, you can see a little bit of progression of cataract, and it might
Okay.
come on a couple of years sooner than it otherwise would. But remember, in Aniridia, the average age for some kind of lens or cataract surgery is in the 20s, right? So it's earlier than it is for the average general population. So is it accelerated from, if you have to have it at 25, is it happening at 24? Could you have glaucoma drops? Well, maybe, but it doesn't seem to cause a big change where people
Okay.
get cataracts.
So there
Just
shouldn't be a severe change,
yeah, it might, there's something, a lot of things with the glaucoma treatments that might accelerate things, and that's true of all treatments of any kind. And even having an eye problem, you can have more accelerated
Right.
tendency towards cataract. So it's hard. I would say that there's no known huge effects on that. Generally speaking, there is a risk though for early onset of, significant cataracts in Aniridia though.
All right, we had one last question in the chat, so we're going to do that one and then wrap up, I think. What do you think about redirecting a tube shunt in order to fit a scleral lens?
That's really a good question. Yeah, I don't think that's necessarily a bad strategy, because that's a relatively minor treatment. If somebody has to have the contact lens to function, it makes sense to me. Nowadays, with the contact lenses, scleral lenses, though, they can actually 3D print them, get impressions. They do impression contact lenses where we take a mold and they can actually mold around those kind of things. So I think you can go to you got a choice. That's one approach is to move the tube. I can get that strategy. We don't do it very much anymore because we now just print, lenses that are scleral lenses that actually take into account those kinds of, bumps and weird things and on different people's eyes that will adapt for that. And they can use the scleral lens that's specifically for their eye.
Okay, excellent. So I think that's all the time we have for questions tonight. I do want to let people know we are working diligently on planning future episodes of Focal Point. We're hoping to do it every 3-ish months, something like that. Our next one, we are talking a little bit right now with Dr. Alex Levin. I believe he's in Rochester, and we're chatting with him about doing a focal point about the basics of eye care in Aniridia children. He is a pediatric ophthalmologist, so that's where we would focus. And then later in the year, again, we're hoping to start hitting on the cornea, since that's a super important topic. So we will be continuing these throughout the year, and hopefully, in years to come as well. We've realized we have enough topics to keep us busy for a lot of years with this. So before we leave, though, I would really love it if everybody could please go ahead and turn on your camera. I have to change a few settings for us to be able to do that. So let me start doing that.
We're gonna get an image of the group.
Yes, I'd like to get an image of everybody that's here. So let's try to make that happen here. I'm going to see if I can get everything done correctly. Let's see here. There we go. All right. I think everybody can now, hopefully, turn on their videos.
If you can, it's
If possible, if you're willing. We would love to be able to see everybody who is here. It's not allowing it, huh? All right, so what do I have set that I don't know I have set? Entirely possible. Oh, let's try again. Now I think it'll work.
Oh, wow.
Now we're starting to see people.
Awesome.
Yay, wonderful.
Awesome.
Let's see here.
Yep.
I need to
That's pretty awesome.
Whole gallery of people.
And some have fallen off already. I noticed there was a higher count earlier. So that's because
yeah.
we're doing an extra minute.
We ran a little long, didn't we? Dr. Netland and I can get a little verbose when we start talking. So, all right, this is great. I'm going to start taking some screenshots, see how many people we can get here.
It's really great to see everybody.
All right. It might take me a minute, guys. It always takes longer than you would think.
Oh, now I couldn't see everybody before, but I see it.
Are you seeing everybody now?
Familiar. Yeah, I see some really familiar faces, and I'm just really excited to see everybody. It's really great.
Let's see here. For some reason, it is not, Sherry or Kelly, are either of you able to take some screenshots? Because it's not wanting to cooperate with me tonight.
That's great.
I just took a couple with my phone.
Oh, wonderful. That might have to work for us tonight because my,
I'm going to give a shout out to Patty there. Patty, say hi to Mark, and don't turn on your video if you don't need to. It's okay. But I just noticed you're on the screen there. So hi.
it's great to see we have people from a number of different countries here tonight, so that's really exciting.
Yeah, it really is
I
impressive.
see Irma here too. Irma is from Aniridia, Europe, and she's living in Spain right now, though.
Yeah.
Hi, Irma, and Mariana, I think, is from Indonesia, so it's exciting to have
This is
her
early
on. And
morning. Wow.
Elena, I think.
Hi, Elena.
And Jenna Cox.
Hi,
Yeah.
Jenna.
So we're seeing a lot of friends here, people from all over, which is exciting. So
Great.
I think we have our screenshots.
Oh,
And,
all right. Let me get one more.
all right, let's make sure we get as many as we can here.
Okay, thanks.
All right, thank you. Thank you all for joining us tonight. I'm going to leave the Zoom active for a few minutes in case anybody wants to do further discussion through the chat of any sort. And so we'll turn it off here in just a couple of minutes. But thanks so much for joining us. We sure appreciate it and look forward to seeing you at another focal point soon.
Yeah, thank you all. Have a great night. Appreciate you being on.
Good night.